Hello, everybody.
We're still figuring out the hybridized world.
Right. So my name is Zoe Corwin, and I'm research professor at the School of Education. For those 30 plus of you on Zoom, welcome. We just did a quick go around here in the room. I wish you could see the room. I don't think that's possible, but we have people in attendance. You want to make that happen? From all different facets of USC, from the School of Education, from social work, from psychology, from CAC. It's kind of amazing what a diverse group was able to join us today. And then we also, I'm super excited, have a lot of members of the community who are here, which really like that, I'm all about that. So I'm so glad you're all here, and thank you for spending the time with us. 30 seconds from me. So I had the great fortune, my colleagues and I, of receiving a grant from the Collaboration Fund out of USC's Office of Research. And it's a very special grant that allows teams to bring together different stakeholders, different collaborators from across USC. So our collaboration fund is about embedding mental health services in non-traditional spaces. And we are doing some creative thinking. This stems from research I've done with skateboarders, with my colleague Neftali Williams and Alan Green and Rafael Angulo, where we're learning about how we're really learning from skateboarders about how they are practicing self-care and well-being and building community. And we're trying to take some of those lessons and share them with the broader community. I will put a link to our website into the chat at some point, and I'll let you all know. But if you look USC Skate, the website will come there. I've also done quite a bit of work using digital tools, gamification techniques, some game-based strategies in helping students learn about college. So think about you role play a college applicant, and you learn the strategies and then what that looks like in real life. And the funding, we had several $1 million invested in that study, and we did a big random control trial in the state of California. And we found that this hybrid approach to using game strategy and gamification and school-to-school competitions had a really positive impact on the schools we were working with. And so that's our collaboration. And then Adam, I'm about to introduce Adam in a second, who will talk about his collaboration fund, or his collaborators collaboration fund. And this is kind of a really special moment because we are bringing together two different collaborations together for this talk. And we're just happy that you're here. Did I miss anything, Adam? I think I covered it all. All right, so Adam Leventhal, tag, you're it.
This is the most boring part of the talk when I'm up. Okay. All right. Well, thank you all for coming. My name is Adam Leventhal. I direct the USC Institute for Addiction Science, and what we're a collaborative network of about 80 faculty and many students and trainees. And we're trying to support interdisciplinary science, education, and community engagement, and a little bit of clinical services. And our institute sponsors a distinguished speaker series. And we had the great fortune of collaborating with Zoe because my dear friend and colleague, Dr. Danielle Ramo, works in this space that really cuts across our two interests. So before I introduce Dr. Ramo, I would like to also just acknowledge our sponsors, which includes the Office of Research here at USC, Provost Office, the Keck School of Medicine, the Doric Peck USC School of Social Work, the USC School of Pharmacy, the Department of Population and Public Health Sciences, and the USC Norris Cancer Center. So we're very interdisciplinary, as you can see. And so let me go ahead and introduce Dr. Ramo. So she is a clinical psychologist, research scientist, writer, and speaker on teen mental health in the digital age. She has led research on addiction and digital intervention lab as an associate professor of psychiatry at UC San Francisco, where her research focused on how to make interventions most effective for adolescents and young adults through technology. And so she was one of the first people in academia really to be driving this movement many years ago. Then she went to Hope Lab, where she studied social media, and apps tools to deliver support. As Chief Clinical Officer of BME Health, where she is now, Dr. Ramo is helping to design and evaluate a digital mental health solution for teens. She has published over 90 peer-reviewed scientific publications, multiple book chapters in the areas of substance use and mental health among young people. She's received grants from the National Institute on Drug Abuse, the National Institute on Minority Health and Health Disparities, and the California Tobacco-Related Disease Research Program. She currently writes a Psychology Today blog, From Z to Alpha, about supporting teens through technology, and she is a Bay Area mom of 3 soon-to-be adolescents. So please let me, yes, right. Yeah, me search. So please let's welcome Dr. Ramo.
Thank you so much, Adam and Zoe. It is such a pleasure to be here. And I am not just saying that. This is the first time I have shared with people in a room under one roof in 2 years. Thank you so much for having me in person. Thank you all for representing the incredible diverse community of USC and the LA area and folks who are making an impact on young lives. Your work is near and dear to my heart as well. And it is so perfect that such a diverse community has come together in this room today, because everything that I have done and the most thrilling part of my entire career has been the chance that I've had to work with folks who are trained and think and have different experiences from me. It is one of the best parts of my career and my life. So I hope to share with you today a little bit about the journey of what my research program was in the Department of Psychiatry at UC San Francisco, then what I did at Hope Lab, and now what I'm doing at BME Health, that bring together 2 main things. The first is work with teens. I've always been deeply interested in young people. And that was first because I saw and experienced challenges when I was an adolescent through friends of mine that had issues that even when we wanted to help, we didn't feel like there were really teen-centric solutions out there to actually get the support that we needed. The other theme throughout my work and my career has been the promise of technology to help design and deliver teen-centric solutions. And when I started this work, technology meant a hard computer that someone might go to a website to see. And if they were lucky and got real special access, they might be able to have live text-based interaction with a human who may have been a therapist. Now we have come so much farther, and I'd love to be able to share with you both where I started and where I've ended up today in this space. The other thing I mentioned around challenges during the adolescent years is that when I started out, I knew, and it's quite common, and it's been common for hundreds of years perhaps, that adolescence is a natural time of risk-taking. It's a time when people do things they've never tried before. They might go do something that they certainly may have been nervous about when they were a kid. And those of us at this stage, certainly of my life, when I hear or see things that adolescents might be doing, I might be horrified because my brain's brakes are in many ways perhaps overdeveloped, right? But it's a stage when it's a natural, comfortable time to try new things. And sometimes those things have negative consequences. So, it might be normal. And in fact, it is literally normal to try drugs or alcohol during the teen years. For some people, they might go on to have problems with drugs or alcohol. It's also a time when we see most mental health challenges arise. And so that means for the first time, teens experience symptoms of depression or anxiety. That again is relatively normal to some extent. But what we're experiencing now and seeing with Gen Z is an unprecedentedly high rate of mental health challenges. We're seeing a generation who is experiencing depression, anxiety, and suicidality far beyond what we've seen in previous generations. This article is an example of one of the front page articles that Matt Richtel, who's a reporter for the New York Times, has been writing throughout the course of this year on the teen mental health struggle. He happens to be a Bay Area dad and a reporter who's been showcasing various aspects of what teens are experiencing today. And he highlights in this particular piece things like the fact that emergency room visits for mental health challenges have skyrocketed among teens. And we kind of knew that this might be happening. We were seeing increased rates of things like depression and anxiety starting to come relatively at an increased rate each year, not surprisingly coinciding with the onset of social media exposure and the vast proliferation of social media. We started to see rates of depression kind of teetering, higher and higher each year. And then the pandemic just hit teens extremely hard. So in addition to adolescent years being ones in which risks tend to be normal, it's also very important and an age at which we over-index on our social relationships. And the ones that were most important to us in our childhood years, relationships with parents, teachers, and other trusted adults, start to become replaced by relationships with peers. And again, we over-index. They are the most important things in many teens' lives. And so when you have a pandemic that brought all the teens in the world and the United States inside, it hit teens particularly hard. So mental health struggles skyrocketed. We're seeing higher rates of things like self-harm and suicidality. And rates of visits to emergency departments for mental health challenges got a lot higher during the pandemic. So let's talk about how my work was well poised to respond to this crisis. I have always been interested in the promise of digital spaces to reach, to engage, and to impact young lives. When I started the work in my research lab at UCSF to bring technology to young people and democratize access to support that teens might need, I'll give you a sense of how long ago it was. Our first intervention used Facebook for teens, and it addressed cigarette smoking. So good news, the rates of cigarette smoking have gone down quite a bit among teens today. And we know that it wouldn't be that useful to deliver a Facebook intervention to teens today. But it started out giving us a model to be able to take a medium like social media that, of course, has only gotten more prolific in the lives of young people, and be able to say, how can we take a tool and a medium that teens and young adults are spending increasing amounts of time on every single day and deliver support that they might not otherwise get, and it might even be more engaging than what they could get if someone came into my research lab or someone came into my therapy office. And it gave us an opportunity to take the models that we had had traditionally in mental health treatment and frankly, get much, much more creative. And we were able to learn things that were more creative and be able to design interventions that were as just so far more deeply teen-centric than what we ever could have done before. Another through line in my work is near and dear to my heart personally is the population of teens who identify as part of the LGBTQIA+ community. Now, this is a community of young people that is interestingly impacted by substance use, mental health, and promise of technology in a unique way. So I've been interested in reaching populations that have traditionally been underserved by the medical model, by traditional intervention models, and queer or LGBTQ plus young people are one such group. We know that LGBTQ plus teens are more likely to use substances, have problems with substance use, and are less likely to be treated in traditional interventions or healthcare settings for a whole host of reasons, because of stigma, because of mistrust of the system, because of access issues, because of poverty issues, because of systemic homophobia and others. And yet the online world has provided a really unique opportunity specifically for LGBTQ plus young people. In 2020, I wrote an op-ed in Scientific American that described the unique challenge and opportunity that young LGBTQ plus people face around technology. On the one hand, technology has been scarier or more detrimental environment to queer young people. They're more likely to face bullying or homophobia in online spaces than they might be in real life. So or I should say the online world might exacerbate exposure to things like bullying and homophobia. So because of that, we have an even riskier situation among queer young people today in the US, and an even greater need for positive interventions that support their mental health. On the other hand, many LGBTQ plus young people say that they are able to find support and community in online spaces that go far and wide above and beyond what they may be able to face in their other kinds of communities. So a queer teen that might not think that they don't know anyone who is LGBTQ plus can go on social media and see amazing, thriving, positive representations of queer young people and adults. So I wanted to take both that increased risk and that amazing opportunity that technology afforded and deliver interventions that spoke directly and specifically to queer young people. So you'll see that theme in some of the examples that I shared today as well. Adam mentioned that I have had three main roles in my career to date, and I'll be sharing with you some of the work and interventions that I've designed with collaborators in each of three places. The first is my research lab in the Department of Psychiatry at UC San Francisco, where I was for 10 years until 2018. I then went to a social innovation lab. Yes, it's I didn't know what it was when I first got a call about it either, but I know now, and I'm happy to share a little bit more about Hope Lab, which builds behavior change tech for teens. It is a nonprofit, privately funded lab that helps teens make positive change and improve thriving and resilience. And then earlier, right about a year ago, I joined the leadership team of a startup called Be Me Health. And as Adam shared, we're building a platform that is app-based to support the mental health and thriving of all teens. So I'm very happy to share some of the interventions that we've built, and I am happy to just go through and give you a bunch of examples, and then we'll leave some time at the end for questions if that works and is a good way, okay? And if folks have questions on Zoom, feel free to put them in the chat and I'll make sure I get to them when we get to the Q&A at the end as well. Great. So I mentioned when I started this work, I was designing a quit smoking intervention on Facebook. And at that time, even though we're so much farther than that now around what capabilities social media have to communicate and to impact, we had the ability to design different features and deliver them in both synchronous and asynchronous fashions. And if you think about it, what a quit smoking intervention used to look like before we were thinking like this was someone comes into a group once a week, Wednesdays at 4, the group leader sitting there, they've got whatever other group members show up, and you've got your 1 hour. As a leader, you've got only that hour to impact those people. If they don't show, you can't make that impact. And you hope they come enough times to probably get a benefit. And we know from a lot of research studies, that's about, 12 sessions over 12 weeks. And that's a classic CBT intervention, right? Social media gave us the opportunity to intervene in wildly different and unique ways, and for people to really personalize the way they wanted to interact with an intervention. So our first quit smoking intervention, which we called the Tobacco Status Project, and the whole idea was update your smoking status, quit smoking on Facebook, combined the digital tools that social media afforded. We made posts that took classic cognitive and behavioral therapy that helped someone quit smoking, to give them a little something, a skill each day for 3 full months. And here's an example of one of the posts and what they look like, and just asked people to comment every single day on those posts. That's how we knew they were trying the skill. We also knew that we thought there had to be some kind of live human component to get them to actually practice those skills and feel that connection, which is similar to a group leader if they were in a quit smoking group. So this was my postdoc at the time, Johannes Trull. He's now faculty in the School of Public Health in Baltimore. And he has taken this model even further down, amazing daily interventions. But he ran live CBT groups that were ask the counselor, ask the doctor anything about smoking or quitting. And we knew that for some people, they would want to take advantage of a live chance to interact with a real person synchronously. And then the third piece of the model was we knew how to deliver a classic evidence-based quit smoking treatment, but we didn't think there had to be this live component for all of that. So Dr. Trull also was able to go in and deliver CBT asynchronously and have people just see it, take advantage of it, go back and forth, ask questions asynchronously. And we didn't know to what extent people would interact with all these things. We just tried, we put them all out there for 3 full months, and we saw what happened. Now, the first trial, this was my K award funded by NIDA. This was 500 young adults aged 18 to 25. And we looked at teens, half of whom were randomized to the Tobacco Status Project and half who were randomized to National Cancer Institute quit smoking website that also had some social media features. It was called smokefree.gov. And we saw that after 3 months, it was more likely that the people who got the Facebook quit smoking intervention, they had biochemically verified abstinence from smoking. So we knew we were pretty darn sure that they had actually quit smoking. Now, these differences between the two groups, they changed and they got a little more even as a year went on. We had a really, really long follow-up in this intervention. But it was really nice to see that after 12 weeks, we could get a lot of young people to try to quit smoking and to successfully quit. So we knew we were onto something here. And the next stage of this work was to focus more specifically on the LGBTQ+ community. And here we wanted to look at if we tailored this Facebook intervention model directly to queer young people, would it be as enticing as the original intervention was to all young people, and would it impact their outcomes? So here we looked at 2 types of tailoring. First, surface level tailoring. We took the same kinds of posts that we had in the original Tobacco Status Project, and we plopped on some queer flair, if you will. We made it look like images were of folks who might identify with the community, but relatively similar intervention skills. Then we also did what we call deep level tailoring. We talked directly to the community. Many of us who are doing this work were a part of the community, and we talked directly to LGBTQ young people about what and how they would want to quit smoking and what kinds of messages they would want to see. So we were able to talk about community level drivers of smoking and quitting to help tailor the intervention even further. And then our live interactive features were with also a clinical psychologist who was part of the community, who came right out literally when she identified herself and talked about her experience as a queer person, and made sure that the young people understood and connected with her as part of the community. In order to inform the tailoring of this intervention, we conducted focus groups directly on Facebook. And this gives you a sense of, as I was talking about, the opportunity that social media afforded specifically to the queer community. We put out ads on Facebook and said, young people age 18 to 25 who smoke and identify as part of the queer community, would you like to tell us about your smoking experiences? And we were able to recruit people so quickly who shared very openly answers to open-ended questions about their relationships to smoking, what they would want to see in a quit smoking intervention. And then we piloted the intervention with another separate group of young people. And we did things like put out posts, an example of which is on the left. And we asked them, and you can see some of the responses in a live Facebook focus group on the right, we asked them to answer the question that we put on the post, and then also tell us what you think about the post. Give us any and all feedback whatsoever. So you get a sense first at folks' answers to the question, and then below in red is their feedback on the post. So you can literally get these live think aloud protocols that people in fields of marketing use regularly with all different kinds of populations. We were able to run those seamlessly on Facebook with a community, a very diverse LGBTQ plus community recruited from all over the country, and do so in a really dynamic way that gave us data far beyond what we would have gotten if we had just recruited a few people off the streets of San Francisco, right? So again, you get this idea that social media in particular, but also digital tools offer the opportunity to get rich and diverse data in and harness learnings beyond what we could have done before that. So the trial that tested the queer tailored intervention, which is the Put It Out or POP project, was first authored by a colleague of both Adam's and mine, Erin Vogel, who's now at Oklahoma State University. And we looked at the POP intervention compared to the original Tobacco Status Project intervention. So our question was, would that tailored intervention make it more likely that LGBTQ young people would quit smoking? And the answer is yes. In short, teens who got the POP intervention were also more likely to have biochemically verified abstinence from smoking, both at 3 months and at 6 months. And that is compared to the original social media intervention, the TSP. So they both got this 3-month intervention, and yet that tailored intervention was that much more effective and really increased quit rates quite a bit, 3 times over at 6 months. So, what this showed is that the combination of speaking directly to the community, both with the live supports, as well as the way that we delivered digital tools and incorporated the sense of community directly into the intervention, was imperative for this particular population and broadly as we look at young people and the most diverse generation in history. So that was kind of the backbone of the social media intervention model that I developed with colleagues at UCSF. I mentioned it 2018. I moved to a social innovation lab called Hope Lab. Hope Lab is a privately funded philanthropic entity that was founded and funded, still funded today, by the founders of eBay, Pam and Pierre Omidyar. It was funded on a vision that a video game could help young people with cancer adhere to their chemotherapy medication regimen. And this is a doozy of a regimen with an incredible amount of side effects that are very, very hard. And often young kids have to take chemotherapy pills straight for 2 years, and it sucks. So Pam's vision was, could we build a video game that helps young people take control over the process of taking chemotherapy meds, and in turn, make it a little more palatable to have to do something that has so many side effects? And in short, the answer was yes. That was 20 years ago. It had a 20-site clinical trial that proved teens who interacted with a video game called Remission were more likely to take their chemotherapy meds. Hope Lab has blossomed, and when I joined in 2018, was in a much wider space of building other forms of technology-based interventions to address challenges of all sorts, but always focused on the adolescent and young adult population. The unique feature of Hope Lab was that it brought together behavioral science, and that was part of the research department that I joined to help lead, human-centered designers. And this is everything from visual designers who design things as simple as this slide, which is far better than anything I ever presented in my 15 years in academia, down to products that teens will actually want to use, to research designers who talk deeply and get stories from a particular population, turn those stories into personas to really understand deeply a population that we're trying to affect, and then evaluate how the interventions that we build collaboratively are impacting young lives with a lot of qualitative data, stories, again, how are you using a product? And then quantitative data, which was much more my wheelhouse, to be able to truly figure out, have we made something that works? How are they integrating into the lives of young people? And how are they impacting the lives of young people? So I'll share a couple of case studies of the products that we built at Hope Lab. The first one is directly in that social media intervention space that I was working at when I was at UCSF. So I worked collaboratively with Pam Ling, who is the head of a center at UCSF called the Center for Tobacco Control Research and Education. And Pam and I were already working together when I was faculty at UCSF, thinking about how do we bring this social media intervention model to more people? How do we make this a public health effort? How do we take all of the money specifically that the state of California has to help people quit smoking and democratize access to interventions through social media? We partnered with a media company called Rescue that builds campaigns for social change to be able to design advertisements and interventions that young people would find cool and fun and would actually use enough to get the benefit from. And these three entities work together to design a quit vaping intervention for teens on Instagram. So you can see we're getting a little more modern here. We've gone from smoking to vaping. We've gone from Facebook to Instagram. So we had at this point a really sound research literature to say, we've got something that we really think has caught on here. We know that young people are interested in using these social media-based interventions, and we know that they work, at least in the short term. I had a number of grants in the area, and we had at this point about 20 research papers showing that there was real promise to this intervention. But we had never worked collaboratively yet with the power of design and this power that a media company has to be able to deliver both imagery and messaging that is truly and deeply teen-centric. Now, this is not to knock academia. I think one of the best things that I was able to do in developing the model was to say, we have something that we know rigorously can be delivered the same way over time and really likely helps people quit. But what we were able to turn it into when we combined the power of designers and media experts was far more beautiful than anything that ever came out of my lab. So we use the combination of posts on the left, live human coaching on the right, and some fun and interesting tidbits like challenges that we believed would motivate teens and would be more enticing and interesting than the journey that we had developed thus far. We also took things like set a quit date and made them more, again, interesting, beautiful, and were able to make a 4-week journey that included enhancing kids' motivation to quit vaping, setting a date together to let's do this thing, let's quit vaping, and then give the whole group all the skills they needed in order to quit together on day 12. And then do 2 things from that point: support the people who had quit and help those people who weren't able to quit to pick back up and try it again. Here is an example of some of the branding from Quit the Hit. You get a sense of reflections of diversity in the teen vaping community. And these were teens who we had talked to and interviewed to be able to design this intervention. You get the sense of how values were reflected. So the values in the middle were Quit the Hit's key values that we reflected at the beginning of the intervention and that all of the teens agreed to adhere to throughout the course of the intervention. So fostering a sense of community and goal setting and motivation and, let's do this thing. For a lot of teens who were part of Quit the Hit, they said they hadn't, one of the most effective pieces of why they were able to quit was that they were in a group with teens who were all doing this thing together. We also saw particularly high engagement in some pilot groups that we ran with Quit the Hit. Now, we were hoping that we would see, I don't know, a third to a half of the teens in these groups. And this was 2 different pilot projects in South Carolina and in California through the state departments of public health. We were hoping we would get maybe a third to a half of the teens interacting in some way with our coach. We saw far, far higher numbers, more than 3/4 of teens connected with our coach. And Brianna really was incredible. It's a large testament to her ability to motivate teens, but also the importance of that live human connection. And you get a sense here as well of how teens were interacting with each other and using each other as supports, in addition to using both the post that we had designed and the coach. So it's this third factor, which is teens using each other to be able to get support, and some of the examples of how that came out in the group that was also really impactful with Quit the Hit. So we launched 3 different pilot studies, and we saw, as I mentioned in the last slide, high engagement in all 3 in Minnesota, California, and South Carolina. And in addition to generally high engagement, we saw extremely high numbers of teens saying that they tried quitting vaping through interacting with Quit the Hit. They said they felt confident, that they were interested in making a change. They really liked what they saw at Quit the Hit, both the community as well as the design, and they were really interested in recommending Quit the Hit to friends. And this was a time right before the pandemic, when many teens were vaping throughout the United States. And frankly, it was the pandemic before the pandemic. We were using that word to talk about teen vaping. And there's no doubt that many of the teens who came to Quit the Hit groups knew and had many friends who were also vaping. So, the fact that they were willing to recommend Quit the Hit to friends was really a big deal, because you wouldn't recommend something that you didn't think was legitimately cool to friends. We also saw high rates of trying to quit vaping among the teens in the group, and that felt really impactful too. We're evaluating the efficacy of Quit the Hit in a randomized trial now that's led by Dr. Pam Ling at UCSF, and we are recruiting we're trying to get to 500 teens. I'm not sure if we're going to get that high. The pandemic changed so many things, but we're randomizing teens to the Quit the Hit program or a text message intervention in California. And we're going to be able to talk more deeply about how Quit the Hit impacts teens. But we were really proud of some of the early results. All right, so you get a sense of where I started in academia, how much cooler, prettier, and better designed it got when we were able to jump in and collaborate with designers and social marketers. And now I'd love to share another area of intervention that I also worked on at Hope Lab that took on the epidemic of loneliness among college students. So Hope Lab had the unique opportunity to be able to work in spaces and areas that others hadn't worked on before. So it's not working on things like what companies might go after, which is the most prominent or prevalent mental health problem. It can say, what is a problem that people are not talking about or might not be diagnosable, for example, in nature, or that we can't get reimbursed from an insurance company to treat. And that took us squarely to loneliness, something that people talk to a lot about affliction in older adults, but really we were seeing and hearing from young people that loneliness was a deep, deep problem. Again, this is pre-pandemic. It only got worse as we were literally working on this project. So Hope Lab here collaborated with a startup called Grit Digital Health. They were also in the marketing space. They were an advertising firm, but they wanted to get into designing and delivering interventions. And so we worked together to design Nod. And if I can get this to work, I'd love to play you a little video of my former colleague, Caroline Fitzgerald, who led this project, taking us through the Nod app, and you'll get a sense of the design and the intervention.
Say hello to Nod, an app designed to empower students to build social connections in college. Think of Nod as a friendly tool designed to help students build the skills they need to navigate the transition from high school to college and create the social life they desire. Nod's content is grounded in behavioral science and the research of loneliness and social connection. Nod is also shaped by input from over 100 students who have firsthand experience. Let's take a tour. Onboarding lays out how Nod works, but it also does a couple of important jobs. First, using subtle language choice, Nod works to destroy what we call the myth of magical friendship, making clear that social connections actually take time and effort. Second, students complete a value ranking exercise, which customizes what content they're given first. We know from research that people are more motivated to pursue goals that they value. Now we're in the home dashboard. You may notice Nod's clever illustrations. These quirky animals and objects capture the relatable awkwardness that comes with socializing in a new setting. Let's get to the two key components of Nod, challenges and reflections. Challenges are mini missions that encourage students to skillfully socialize out in the real world. Challenges are not random. They're based on the science of social connection and co-developed with students to be relatable and actionable. They're like workout exercises, but for your social life. Opening a challenge allows a student to read the challenge details, see how it aligns to their own priorities, and read a testimonial from another student, all aimed to help the student move from considering to acting, destroying the myth of magical friendship. Once a student accepts the challenge, they can customize their own deadlines and reminders to complete it. What does the research tell us? That making goals that are time-bound increases people's ability to stay on track. The second key component is reflections. Reflections are short in-app exercises that help students process social interactions. Reflections aim to reduce self-criticism and build resilience so they can move towards their goals. It's like the post-workout stretch, but for your mind, building flexibility and thinking. Students first check in using a mood meter, so Nod can guide them to a reflection exercise that best suits how they are feeling. Positive ratings would bring a student to a reflection option like savoring the moment or gratitude, whereas a rating on the opposite side of the spectrum might offer an exercise in reframing, seeing the challenge in a different light, or using self-compassion to process their response. Finally, students can track their challenges and reflections in My Journey, revisiting their progress. Supporting students in creating a healthy social life is no small task. Nod is here to help.
Great. So I hope you have a sense from that things got even more interesting, beautiful. And while there was grounding in the science of behavior change, mindfulness-based self-compassion, cognitive behavioral coping skills, it looked and felt like something that college students would want to use. But we didn't take our word for it or my word for it. We conducted a randomized trial in collaboration with the University of Oregon and found that after using NOD for a month, teens who started their freshman year of college at risk for depression were less likely to have depression symptoms and symptoms of loneliness a month in than students who didn't use NOD. So NOD buffered those high-risk students from having what could have been a really rough semester. It could have led to dropout at the end of the semester or the year, but instead it supported them feeling less lonely and more connected to their colleagues. In the interest of time, I'm going to jump quickly into two last things and leave you just with some resources to follow up and get more information, and then we'll have a chance to ask some questions. So the last project that I worked on at Hope Lab before I left focused again on the LGBTQ plus mental health space. And this is one that I know a number of you are working collaboratively and actively with teens today. It was recently launched this year and it's available for free on the web. So I encourage you to go check out this guide and share it with young people who you know in your lives, specifically those who identify as part of the community. This is called the IME Guide, IMI. And the website to access IME for free is imi.guide. And it is a guide for identity development and support of thriving resilience and coping skills among queer teens. All aspects of what we developed were designed entirely with LGBTQ plus young people and the centers that support them and the organizations that support them. And they also have a look and feel that is grounded deeply in the reflections of the community themselves. So everything from stories, activities, the learning of coping skills to bolster their ability to get along in the world with a number of risk factors, and beautiful and engaging illustrations. So please check out IME.guide if you're interested in finding out more. And it is and will always be free for young people. And then the very last thing I'll share, again, it is so, I'm going to brush through just in the interest of time, because I'd love to just share quickly what we've built at the startup where I'm now Chief Clinical Officer, and then you can ask me more questions about it as we go, but I'll just share one slide. So in October of last year, I joined the leadership team of a seed stage startup called BeMe Health. BeMe brought together a combination of behavioral science leaders, technology experts, and folks in the entrepreneur community who were all coming from the lens of wanting to take on the teen mental health crisis and realizing that we couldn't do it unless we were entirely teen-centric through and through, and unless we collaborated with folks who have expertise that is far beyond ours. We also knew that we needed to collaborate deeply with and establish a teen advisory board. So we have 80 teens from across the country who we meet with every single week, live on Zoom and also digitally constantly, through which we run every single aspect of our app-based platform. And these teens, I mean, we don't do anything without getting their feedback. I'd love to just show you a sense of what we've built, and then I'll end there. So BeMe launched in January with our first app-based product. We're live in the Apple and Android stores, and teens today can get age 13 to 19 can get free access to BeMe. That won't always be the case, but for those of you, especially folks from the Boys and Girls Club and other community-based settings where you're interacting with a lot of teens, please know that it is entirely free today for teens. It has both digital supports, and that is part of the two images on the left. We have content that looks and feels a lot like social media, but it's actually coping skills that help teens deal with all the challenges they might be facing. Everything from depression and anxiety to friend fights, and I have too much homework and a test on Friday and I'm supposed to be practicing soccer and my coach is yelling at me and my mom is yelling at me. to interactive activities to be able to practice the skills that they learn from the content. And then remembering back from the social media intervention model I mentioned at the outset, we've known all the while that a live human component is necessary and increases the likelihood that teens will get a benefit out of an app like Be Me. So we've designed our own coaching model, which you see in the middle, that's text-based coaching that teens can text in 14 hours a day and get a live coach that's trained by Be Me that helps them find the skill that's right for them and use it and practice it so that they can use it off of the app. We also connect teens who need it to therapy and psychiatry services, and we offer 24/7 crisis support for those teens who also might need it most. So they can get a live human on the phone or get directly connected to the crisis text line or the Trevor Project. Because as part of this pandemic has shown us, unfortunately, the rate of crisis among teens is unusually high right now. But the idea is if teens are coming to Be Me and using it in an interactive fashion, before they're in a crisis state, they'll be able to come back and use the safety tools if and when a crisis does occur. So with that, I will pause there. And I know there's not a lot of time left, and I went through a ton of things, but I would be very happy to take any questions that you all have. Thank you so much.